Welcome, everyone, and thank you for joining us for Session 2 of the Audit Proof Your Agency webinar series presented by CHAP and SimiTree. Today's focus is on home health and hospice compliance. In this session, we'll explore the core framework and requirements that every agency must have in place, from CHAP standards and the OIG 7 elements to the common compliance focus areas auditors look for. At the end of this presentation, a QR code will appear. Simply scan it to complete the attestation required for your continuing education credit. A recording will be available on YouTube, and your CE certificate will be emailed to you afterward. And throughout the webinar, please use the Q&A box to share your questions. We'll address as many as we can during the session. With that, I'll turn it over to Deb Grott from SimiTree to kick us off.
All right. Well, good afternoon, everybody. As Dan said, my name is Deb Grott. I'm the Vice President of Clinical Compliance here at SimiTree, and it's great to see everybody. Many of you joining us here for this second session of our compliance series. In this session, we're going to be doing an overview, as Dan said, of the importance of our compliance program and the current status of government audits here, the current state of government audits. So, and to note, just to let you know, it's important to think that this is a 4-part series, so you don't want to miss our next part, which is session 3, and that will be a lot more detail related to the 7 elements of compliance and some of the things that we're touching on today. So it's great to see everybody, and we're going to get started. So the first thing I want to talk about is the overview. If you could go back one, Kim. Just talk a little bit about the overview of what we're going to do. So we're going to talk about the key government audits that are going on right now in home health and hospice. We're going to talk about the intersections between regulatory and billing compliance, which is very important, the importance of establishing and implementing a compliance program, the structure of that program, the 7 elements, and the CHAP compliance standards, general strategies and resources that can be used to demonstrate your organizational-wide compliance program and culture. And then we're going to do a Q&A session at the end. So we look forward to you submitting any questions that you have as we go through. Next slide. So for us here, there is a bucket of compliance, which has a spillover effect, starts with HIPAA and the enforcement of the Department of Health and Human Services and the Office of the Civil Rights, spills over into billing and payment requirements, which are your provider manuals and your MACs, CMS oversight, OIG, Department of Justice, and the state Medicare fraud units, and then the conditions of participation. So our buckets for compliance, there's always 3 full ones. They all cross and intersect into each other, and it's very important to understand that those pieces are going to intersect as we go through this program. Next slide. So we're going to talk about compliance and regulatory and the landscape that we're currently in. I'm sure a lot of you already know a lot about what's going on out there, but we're going to talk a little bit about government audit updates. So if you are unsure, there are many different pieces of government audit contractors that you can see audits from. You're probably very familiar with your MAC, the Medicare Administrative Contractor. That would be Palmetto, CGS, or NGS, depending upon what part of the country you live in. They are responsible for doing medical reviews, especially in the targeted probe and educate area, which we're all familiar with. That's that 20 to 40 claim audit that you can get annually. And a lot of agencies are seeing those currently. And also in certain states, we have the review choice demonstration that is being held for home health, and that's through Palmetto typically. And so if you're in one of those CMS states in home health, or RCD states in home health, you may be seeing you may be seeing review choice demonstration. I'm mixed up in my acronyms today. Then we've got the UPICs, the Unified Program Integrity Contractors. That's your Safeguard Services, Clarent, or Covered Bridge. Remember that the UPICs are looking at data mined information, and they may be getting information from those TPEs that you're doing, and they take that information and determine if they need to take a step deeper into your agency to take a look at some maybe deeper audits within your agency related to billing practices. We have the SMRCs, the Supplemental Medical Review Contractors by Noridian. The same thing, they use a lot of data mining information. We're seeing a lot of SMRCs currently in the hospice and home health world. And they are also taking information from other government entities as well. So the MACs, they're seeing information from the MACs, from the TPEs, and they may be picking you up for one of these SMRC audits. The recovery audit contractors for home health and hospice, or the performance recovery incorporated contractors, they typically will poke their nose in a couple times a year, sometimes once a year. They'll pull 3 or 4 audits for you, and they'll see what your performance looks like within that within those areas of billing. So they're looking in, you may see them one time a year for 3 or 4 audits. And then if they don't like what they see, they kind of pass you on to some of those other government agencies as well. And then we've got the CERTs, which are the comprehensive rate error testing. They're the federal oversight that does oversight on the MACs. So that's when like CMS steps in and does federal oversight on the MACs to ensure that they're doing the things that they need to do in the audit processes that they're following. Next slide. Oh, sorry.
Deb, I think it's important to also point out, you made a great point when you said they dig deeper. What we're seeing in a lot of cases is they're now asking for entire records, including personnel information as a part of that. And so we're seeing that they're really cross-referencing to a lot of additional information we didn't see in the past.
Yes, absolutely. Absolutely. So the big thing is, why are home health and hospice providers targeted for focus audits? As you can imagine, the home health and hospice benefits continue to increase for the Medicare beneficiaries. The baby boomers are getting older. A lot of people are taking, being able to get the care from either home health or hospice as needed. So there's a lot of federal dollars going that way. So when that happens, you know, that causes that government increased scrutiny. There's monitoring that's spending outside of the Medicare hospice benefit. And I don't know, Lori, if you want to comment on that part of it, the monitoring of the spending that's outside the Medicare hospice benefit. I know you and I do a lot with that.
We do. And we see, especially in the hospice world, they're looking at your pharmaceuticals. So there is the hospice covering all the medication that's related? They're starting, and we'll see more of it, I think, with the HOPE being implemented in October, where there's cross-referencing to what we said our diagnoses were and what our comorbid diagnoses were and what we paid for and what services we provide. We know that hospitalization is also being cross-referenced. And then if we had live discharges. So they're data mining our information against other providers and other payers to see if there are crossover in those information and is there duplicate payment being made in areas where there shouldn't be.
Yeah, absolutely. And then we've got overpayments and fraud and abuse practices. They are real. I mean, we are seeing the government entities looking into fraud and abuse practices all of the time and making sure that what we're billing for is the services that we're providing on both the home health and the hospice sides. Mandates that are under the Patient Protection and Affordable Care Act, the ACA Act. Government initiatives. Every year, the government comes out with specific initiatives, whether that's OIG initiatives or MAC initiatives, things that they are specifically looking at. So we're seeing areas of increased focus related to government initiatives. The government reporting of demonstration patterns of potential or actual abusive practices. What happens is when they do these initiatives, they report back the potential and the actual abuse practices that they find, which then leads to additional initiatives for the government to do more audits. So it's really a circle effect. One agency talks to another agency, they they come up with additional initiatives that they want to look at, and they continue to do these focused audits related to it. The big thing is this government data analytics helping to determine who will be targeted on the next audit. Pepper reports used to be the big thing that were used all of the time. We know that Pepper has gone by the wayside for the past few years, but there is still data mining going on with the comparison of state, regional, MAC jurisdictions, national audit findings, and then claims, quality, and beneficiary data. So the government is using data mining techniques to determine who their targets are going to be related to home health and hospice audits. So it's very interesting to see the data mining that is going on. Lori, do you have anything additional on that?
Yeah, I was just going to say, I think we also need to take note that what the government is doing as far as the OIG and the DOJ is not necessarily one time a year. We used to get, one big report, and we still sometimes do that, but they are constantly providing updates to us. So it's really important that you're watching those updates to see where their focuses are. That's really good guidance, so that we know where they're headed next or where they're currently concentrating on information. So don't think that it's just a once a year process.
Yeah, absolutely. Absolutely. And we are seeing increased scrutiny all the way around. So areas of focus by the government for home health. Face-to-face encounters. They have been a source of government focus for several years. Same with skilled need and medical necessity. Is that patient really qualified, and are you really providing skilled care and medically necessary care under the home health benefit? Long lengths of stay in home health. So, we're used to talking about long lengths of stay in hospice, but long lengths of stay in home health are also scrutinized. You've got those long-term Foley patients. You've got those long-term wound care patients that you're working with. They're really looking to see that every visit that you're providing contains that skilled and medically necessary care, and does that patient really qualify to stay on your service for a longer length of stay? The same thing with short length of stays, right? So the LUPAs or just over the LUPAs. Again, those patients that are like Foley catheter patients, injection patients that you may be going out once a month to do an injection or every other week, they either fall into the LUPA category or just over the LUPA category. So they're looking to ensure that the care that you're providing really does meet a skilled and medically necessary and homebound status. Obviously, it ties into the next, but and that those patients continue to be homebound as well. Homebound status is another one. You really need to support that homebound status throughout your episodes of care for your home health patients. And that really just shouldn't be the checkboxes in your EMR. It really should be patient-specific homebound status to support the two levels of homebound status, right? So you shouldn't just have those checkboxes in your EMR. And we see that a lot. Therapy utilizations, your PT, OT speech, and duplication of services. Is your OT doing the same thing that your PT is doing? Is the speech therapy in there really doing something that's relevant to the patient's swallowing and techniques for speech and or related to a lot of times the CVA? They're really scrutinizing each individual therapy to ensure that they can stand alone. They're not doing duplicate services. And you're following the technical guidelines as well for therapy. So you're doing those 30-day reassessments. And those 30-day reassessments are supporting the need for continued home health service for those therapy patients. So those therapy utilization 30-day therapy reassessments need to contain objective measures and continued support comparative data to continue the care for PT and OT and even speech. And then, of course, we're always seeing low-hanging fruit, which is the technical denials. Signatures on the plan of care are legible, no dates on the plan of care. So there are technical requirements that you need to meet, making sure that you have your dates for your face-to-face on your plan of care or an attestation statement on your plan of care. There are technical denials that can get you a low-hanging fruit denial, and they are really increased high government scrutinized areas. Next slide.
Deb, I think on that signature piece also with the use of electronic EMRs that we need to be sure that we're familiar with what constitutes an electronic signature.
Yes.
We are seeing denials for that also as well.
Yeah, I agree with that. We're seeing a lot of increased scrutiny around what appears to be a wet signature and then a typed date, and then no entry on there to tell us whether it is a digital signature, an electronic signature, no designation. So it's really important that you're looking at your signatures that you're receiving and making sure that you're looking at the CMS guidelines for electronic signatures and ensuring that they're meeting the guidelines for those electronic signatures. That's a great point, Lori. Areas of focus for the government for hospice, eligibility and medical necessity to support that 6-month prognosis, right? That terminal trajectory of 6-month prognosis is really a highly scrutinized area. Levels of care, routine respite, GIP, and continuous care. We're seeing a lot of times where GIP visits are being downgraded to routine visits because they don't have the support and documentation to support that general inpatient stay. So that's really important. Lengths of stay that are over 180 days. It's really, the government is really scrutinizing the CTIs, the narratives, the face-to-faces that are being done, the clinical documentation surrounding that patient to ensure that the terminal trajectory for this patient, the documentation supports the terminal trajectory for the patient. Utilizing the LCD guidelines and things like that in the documentation to ensure that we're supporting the things that need to be supported to show that that patient, yes, may have a longer length of stay, but all of the documentation supports that that patient is on a terminal path. It's just a little slower than maybe expected, and they're continuing to document well. Patients that are living in SNFs or ALFs, hospice, they're high scrutinized areas because we want to make sure that the care that they're providing from the hospices are meeting the terminal trajectory, and that those patients in the SNFs and ALFs are meeting that criteria to support that 6-month prognosis or less. Technical requirements. Election statements, waiver language, patient choice of attending, CTI, face-to-face, and now the new NOE addendum. It's really not new anymore, but the language on there, making sure that your BFCCQIO language is up to date, making sure that you're documenting the things that are covered and not covered under your hospice allowances, making sure that if the patient is choosing and attending, that it's documented. All of those things are technical requirements that we're seeing, making sure that everything is signed appropriately as well. Medications paid for by Part D related to hospice diagnosis and prognosis. Lori kind of touched on this a little bit when we were talking about this before, making sure that these are documented and related to the hospice diagnosis and prognosis. Inappropriate referrals, making sure that any referral, whether this is home health or hospice, is appropriate for the care that you're going to provide. And then, of course, paying hospice medical directors more than the fair market value. That, again, is also scrutinized in home health, but we use medical directors in a much more focused area in hospice. So that is really an area of focus. Lori, do you have anything to add to this?
I was just going to say, when we talk about long length of stay, while that 180-day 6-month prognosis piece is important, we are also seeing reviews where they're looking at documentation to support medical necessity month to month. So when you look at the audit actually that's occurring, many times we'll see requests for monthly data. And so they do want to see that you're providing that quantifiable, objective, comparative data that supports changes and appropriateness for eligibility ongoing from month to month. We do sometimes see months denied. So there's much more scrutiny around those pieces of information.
Yeah, absolutely. I feel like we concentrated on benefit periods for a long time, and now they're really into the month-to-month scrutinization. I agree.
Yeah.
So,
Kim, Kim, are you guys as a survey agency with CHAP, are you seeing increased scrutiny in what you're being asked to look at in these areas?
So thanks, Lori. Hello, everybody. What we see, and this is coming in the next section here, is remember that the AOs as survey agencies and your state survey agencies, we focus on what really the COPs, the conditions of participation and regulation. So we're not conducting compliance audits, billing compliance audits, or looking with the same lens that a government auditor would look at, or that such as your organization supports providers with, in terms of looking through the lens of payment. That being said, there has been an increase in request from CMS. We did receive a memo back in November of 2024, directing, if you will, or requesting that AOs and state agencies do report to CPI, Center for Program Integrity, and CMS any potential fraudulent behavior. So we're not necessarily looking at it with the same lens of specificity for the technical requirements, if you will, of a face-to-face, for example, and not with the eyes of eligibility. It's more an overall fraud, potential fraud. In other words, are they operating where they say they're going to operate? Are they overall providing care appropriate to meet the patient's needs? And if we see situations that we question, we do refer, or have been asked to refer, and we do refer to the state and also to CMS when we have that, especially in all states. I would say this, in all states, for all Medicare certified organizations, but we also would specifically, we received that directive for the target states for hospice. In California, Nevada, Arizona, and Texas. So I will say that we're very fortunate that we don't have to make those referrals very often. But to your point, Lori, there is more of a lens, if you will, a broadening of the lens. So again, we don't conduct payment audits for eligibility, but if we see trends, for example, that we think may be questionable, because remember, we do not look at billing. We only look at regulation, and then there may be follow-up.
Yeah, thanks for that, because we are seeing, as you mentioned, state agencies coming in and looking at the technical pieces around the notice of election in those areas.
Yep.
Yeah. And I think Kim brought up a really great point that, and Lori will talk about this, and Kim a little bit later as well, that there is some overlap between the COPs and the billing, but in the eyes of the government, they're really separate. They're looking at separate scrutinized lens with a separate lens. So there's billing, that billing compliance, and then there's the COP compliance. There is some overlap related to your compliance program, but it is important to understand that they don't correlate. I've had a great survey. That doesn't mean you're going to have a great billing audit or vice versa. So that's an important piece. So the landscape in 2025, wow. I'm going to tell you that the government has woke up. I would say the first 6 months of the year, it was a little slow with government audits, but I think starting in May and June, they really kicked up. There is a lot of increased scrutiny right now for fraud and abuse. There's a lot of increased UPIC activity, MAC activity surrounding the TPEs and other audits. The RACs have woke up. So if you're not seeing government audits in your agencies right now, you're pretty lucky, because most people are. The really big thing that's going on is the PPEO states, that special enforcement targeting that's going on in California, Nevada, Arizona, and Texas. It's important to note in these 4 states, for both brand new providers or existing providers that may have gone through a CHOW or some kind of ownership change or restructuring, that this period of payment enhanced oversight is going on in those 4 states. I describe the PPEO as a TPE on steroids. because honestly, and should I say this is just for hospice, this particular PPEO. It is like a TPE on steroids. You can get into one of these PPEOs, and unfortunately, we've seen some agencies go on fast track for decertification if they're not careful. So it's really important to understand that if you're going through some kind of restructuring, a CHOW, or you're a brand new agency, a hospice agency in these 4 states, you will get a PPEO versus a TPE. So it's important to understand that PPEO piece. In home health, we're seeing things as well. We're seeing TPEs for initials, brand new starts of care or CHOWs, change of ownerships in home health. We're seeing the TPEs in all of the states for that. State operations manual changes for Appendix B and Appendix M. So these took place a year or so ago, and really the changes that have gone on there are really related to survey process mainly. And what we're seeing is for the survey teams in hospice, they're made up of more interdisciplinary teams. So typically you always have a nurse go, but if they're sending more than one out on a hospice survey, you're typically seeing other disciplines going, maybe a social worker or something like that, where in the past we've typically seen just nurses. There's also been more training for the surveyors. So the surveyors are better trained and better focused on the things that are going on related to the COPs. There's also been consolidation of certain G&L tags. And then we've seen a lower tolerance for condition level and immediate jeopardy level findings and citations that have been going on. So I know Kim has some things to add to that because that is right in her wheelhouse. So Kim, what's going on with the changes with the Psalms?
Sure. Hi. Thanks, Deb. Basically, as Deb pointed out, the changes to Appendix B, home health, and Appendix M for hospice were updated to align the survey processes across CMS settings and provide a more informative, if you will, guidance related to the survey process itself. There were not significant changes to the COPs themselves, except in some renumbering, although there have been new standards implemented in the last couple of years for both hospice, for example, with marriage and family therapists and mental health counselors, and home health with the acceptance to care policies. But generally speaking, what we have found is it appears to, really has strengthened the survey process and very clear guidance for providers who are conducting their own or implementing their own survey readiness process, because it is very consistent with, again, what our expectations are. As far as training goes, certainly for CHAP and for AOs, we continue to have the CMS requirements for QSEP training, for basic training, and but also making sure that we have a conflict of interest process in place as well. So just a little bit of tightening oversight there. We have not seen a substantial change in terms of organizations' compliance with the standards. It just really implements the survey process. That being said, you are correct. Across the country, there is an overall increase, not related to just AOs, but to all survey entities related to condition level deficiencies and immediate jeopardy. So that's something that organizations need to keep in mind. With that, Deb, if you want, I can go over the strengthening of the oversight of the AOs.
Sure.
Sure. So as Deb pointed out, yes, the focus has been on payment compliance with providers from the federal government, but know that also accrediting organizations, or AOs, such as CHAP, Joint Commission, and ACHC, we also we are contracted with CMS, or awarded the ability to be able to accredit with deemed status or Medicare certification. And this is a certification approval process that occurs through CMS every several years. So up to 6 years is the deeming approval process. with the oversight of AOs, a few things have occurred, enhanced over the past year, and that includes direct observation visit surveys, or DOVE surveys, for deemed organizations. Many of you may remember validation surveys from several years ago, where the state or a state agency or CMS would follow an accrediting organization for up to 5% of deemed agencies, which would result in 2 surveys, potentially 2 separate sets of findings, and 2 plans of correction. The CMS implemented a couple of years ago a pilot, and most recently, as the beginning of this year, the DOVE survey, which is through a CMS contractor, who the contractor actually arrives and participates in the survey with the AO. So the CMS contractor conducts or participates in the survey, meaning they observe the AO. They are not there to also conduct a survey. They don't review actual records. They don't issue citations. They are observing the AO process. This has been, again, for all AOs. It was put on hold earlier this year, but we have received word that it is likely to resume later this fall. And I can speak for CHAP that we found the DOVE process to be much better, much more effective, I think better for customers, and certainly from our findings, we had excellent findings, no findings, we actually had excellent surveys and feedback, and it was a collaborative process. So I say this to you because should you have a survey and a CMS contractor is also with the AO surveyor, you will have, just know that they're not surveying you. We now also have to have state agency approval prior to initial deemed surveys. What that means is it used to be that the agency would go through licensure, get the state agency approval, and then it would go to CMS or the MAC for approval. We would get the notification that we could then conduct a survey. We now go back to the state agency to obtain one more approval to make sure that it's okay to be able to go out. It has not impacted our timeliness to survey now that all the states are on board, but this was implemented last August. And then there was a proposed rule for strengthening the oversight of AOs. This language was in a separate proposed rule that is still pending. However, in the home health proposed rule, many of those provisions were included in the DME portion provisions in the home health proposed rule. So it's clear that there is, a continued oversight with AOs, and making sure that, that we are consistent and meeting the intent of the program. Thanks, Deb.
Awesome. Thanks, Kim. All right, next slide.
If I can get to it, hold on. There we go. I'll sign off now.
Yep. So we're moving on to the next section, which is Lori. So I'm going to turn it over to Lori.
Good afternoon. I'm Laurie Newland. I'm a senior manager with SimiTree Healthcare Consulting. I have a master's degree in nursing. My background is I have worked as accreditation surveyor and other roles with CHAP in the past. I've been a compliance officer. I'm certified in compliance and privacy, and have lots of years in hospice, palliative care, and home care services. As in my current role with SimiTree, we not only work with organizations who have survey issues and regulatory issues, but we also work with those who are developing or working on their compliance programs or have billing issues as well. And that's what I'm going to talk about this afternoon, is kind of the intersection between each of those things and how they overlap and how they're all important and have similar background related to what's important when you're looking at those pieces of information, so that you can have an organization that really meets regulatory requirements and shows that you are in good faith implementing all the regulatory requirements. Next slide, please. Okay, on this next slide, we're going to talk about the conditions of participation. And as Kim referenced to, this is really the COPs and the survey readiness piece related to what we see when we're looking at regulatory requirements. These are also applicable in some other places, not just in the reference that I have on this slide, and we'll talk about that in just a few minutes. And the purpose of the survey is to provide guidance and ensure federal and state requirements are met while verifying the quality of care. When a surveyor is on location, they're out seeing your patients, they're looking at your organization, they're ensuring that the patient care that you provide reflects the quality that is outlined in the conditions of participation, and that you're meeting those requirements based on not only what they see, but what you document within the organization. So one of the things you'll see as we talk through this section is how important the documentation review is within your organization, and the things that you can do to ensure that you kind of meet those pieces. You can find that information for home health, primarily in Appendix B of the Home Health Manual, and you've got references here. You guys will receive copies of this PowerPoint and a handout related to it. And then Appendix M, as they refer to as the SOM, which is the State Operations Manual for Hospice. But there's also other applicable appendices which we need to look at. Things like the appendices for emergency preparedness, which are applicable to both service lines, and many of the others that you need to have in place. And you want to be familiar with the Program Integrity Manual, as there are pieces in there that are applicable to all service lines as well. The document review intersects all these processes through the auditing and monitoring process. Today's presentation is really an overview of what we'll be covering more in depth later. So I'm just going to mention some of these things, and we will be going more in depth in subsequent presentations and a little bit more today as well. While the surveyors can look at the patient and the environment of care while they're on site, the description that's most important or providing evidence of your quality of care, the appropriateness of service, in addition to your billing compliance. And they see that not only in observation as a part of the survey, but also in the documentation that you provide. Next slide. So when we look at the billing review, we reference to billing manuals, and we have billing manuals for both home health and hospice. We have multiple chapters which apply to both. If you're not familiar with those, it's really important that you do familiarize yourself with them, because these are kind of secondary guidelines that go to how we document and what we present when a billing review occurs. Now, Kim stated that while as a part of the survey readiness, they're not really looking at and doing a billing manual. They are looking at your documentation, which should cover those guidelines and clearly paint a picture of those patients who are on service. The billing guidelines typically not only apply to Medicare and generally Medicaid, but also most third-party payers follow those guidelines as well. They may have some supplemental things, but they will basically cover a lot of the same issues. And then the purpose of the billing manuals, again, is to ensure that quality of care as well as fair compensation for the services that you're providing. And the way that they see that really on a billing manual is solely through documentation review. As we said earlier, they're asking for additional documentation that hasn't been asked for in the past. And so some of the things that you see on survey, like your review of your plan of care, for hospices, the review of your IDG process, they're also wanting to see those pieces of documentation to ensure that not only are you meeting the billing requirements, but you're also meeting the conditions of participation around those service lines to show that these patients are applicable to service, that they're eligible for what you're providing, and that it's really necessary, that the services that are being provided. So it's important that your documentation really reflect all these pieces. And what we have here is the reference sections for the Medicare Benefit Policy Manual. For home health, that's Chapter 7. For hospice, Chapter 9. And in addition to that, for home health, we have Chapter 10 in the Claims Processing Manual and Chapter 11 for hospice in the Claims Processing Manual. And while some third-party auditors may have some different criteria, as I said, they do look at the Medicare requirements and the documentation to support the right to bill for services provided. They all want to see that there's evidence that they are being billed for, and what you are being reimbursed is for reasonable and necessary care that meets the regulatory requirements that are provided. And the guidance for appropriate billing is found in these sections of both the Benefit Policy Manual and the Billing Manual. And as a part of the survey process, that face-to-face review as well as the documentation review is really important. So you want to be sure that the quality and completion of your documentation reflects quantifiable objective data that brings comparison in so that they can see what the process is in hospice, how your patient's declining, in home health, how they're meeting goals that are important for achieving your plan of care. Next slide. So when we look at the OIG compliance program guidance, this is really put out by the Office of the Inspector General, and it's presented as a basic plan for all service lines. Now, they have been working on some service line specific requirements, and currently those are elective requirements. They're not necessarily mandatory, but I will tell you that they are very important because their goal really is to look for fraud, waste, and abuse. And so if you have a functioning compliance program in place where you can show that you really are focused on compliance and meeting those requirements, should you be reviewed, it really goes a long way to support what you're doing in your program. These are crucial for promoting ethical practices, protecting patient rights, preventing fraud, waste, and abuse, and maintaining the overall integrity of healthcare operations. They increase proper submission and payment of claims and reduce billing errors. They assist in avoiding the potential for fraud, waste, and abuse. They assist in promoting patient safety and quality of care and providing protection against government enforcement actions. So the basis for all our reviews is to protect the payer against fraud, waste, and abuse, and to ensure that appropriate care is being provided. The Office of the Inspector General, as well as the DOJ, the Department of Justice, they're federal players who provide guidance and may become involved in a review should that be referred from other review agencies, because they want to ensure that we're not only meeting the care requirements, but also those billing requirements. And as I said, while a compliance program at this point in time for healthcare organizations is not mandatory, it is highly recommended. And should you have a CIA, a corporate integrity agreement, anything like that, it's going to carry weight that you had these pieces in place. And it really shows how your organization as a whole are committed to ensuring that you have compliance within your organizations. Kim, as a part of the AO, do you want to talk about how that's important for you all? Because that's a little different than what we see in the typical conditions of participation.
Sure. So from our perspective, and we'll talk more about this in our other sessions as well, certainly from CHAP's perspective, we have established compliance standards which mirror the OIG 7 elements of a compliance program, which we'll talk about again in further detail. From our perspective, as you had noted when we're reviewing a survey, we will, our focus is on quality of care. Is the patient receiving appropriate care at the level of care that they need, whether that's hospice or home health, right? In hospice, the levels of care, but also is in home health, is the agency receiving, the patient receiving care, the services, care, treatment, and services that they need based on their condition. And so we look primarily at the quality of care and health and safety of patients, but ensuring that an organization has a compliance program goes a long way in terms of, to your point, really supporting that the agency is proactive in avoiding or mitigating any, any potential fraud, waste, and abuse, and that their billing and clinical documentation practices meet standards, all of the standards that we're talking about, whether it's regulatory in the COPs or in conditions of payment.
Thank you. I think that's important because we do sometimes get questions about why the state may not be looking at everything that the accreditation organizations are looking at. And some of those are your accreditation standards that really support you going above and beyond what is the basic minimum. So that's really important piece of information. Next slide. So when we look at this intersection between the COPs, the payment, and the OIG program guidance, as Kim referenced to, for the conditions of participation, those are the things that while they're on site, they're looking at care that's provided, the Medicare billing manual, how you're documenting and supporting your payment, and then the OIG 7 elements of an effective compliance program, which were developed by the OIG and are supplemented already for some specific service lines, but there are general requirements provided as a part of the OIG guidance for any organization. And the purpose is really to provide that guidance and ensure federal and state requirements are met while verifying quality of care as well as fair compensation, and to help providers detect fraud, waste, and abuse within your organization. They would certainly much prefer that we find those within our own organization, stop them, and have a process in place to monitor for that versus them having to come in, find those, and then we're subject to additional fines, maybe having our license pulled, all those pieces. And that's really the intersection. When you look at these three pieces where they overlap, their goals are really the same, and they want to ensure that they're not really out to get us. They've really provided us guidance on how we can meet the requirements and ensure that what we're being paid for and the services we provided are safe for our patients, and we are able to bill for those things and provide services for the beneficiaries. Next slide. So these areas of overlap, when we talk about, and we're going to talk just briefly here about some of the things that are included in the OIG 7 elements, but you'll see that these are really important also when you look inside your organization to show that you really have a compliant organization. It overlaps everything that you're doing within your organization, and it's bought in by everyone. And that starts with training. So when we talk about training, it's not only compliance, it's also regulatory requirements and the responsibility kind of all the members of the organization and their responsibility related to compliance, the enduring effectiveness of that. Within each of our organizations, we have outlines of what training has to be provided. Some of those are mandated by the government. Some of those are our internal training things, but we have process in place where we review those. We do them initially, we do them through periodic times, we do them as things that are more urgent come up or where we find areas that we might need improvement. So we all see that within our organizations. When we look at policies and procedures, we should all have policies and procedures in place, and they really provide a guidance document for reference and enforcement of expectations. So they're a place where not only are we teaching from those, but any member of our organization can go back to them at any time as a reference. So I can't remember everything that's in a policy and procedure, but it's important that I have a reference place, or sometimes I'll hear people say that's sort of the Bible for the organization, where they know that they can reference things and see what the goals are within the organization and how they need to get there. And then we want to talk about the designation of a compliance committee. So organizations who already have a compliance program in place will have a compliance committee. That's really a cross-section of people within your organization who are not the only ones involved, but do take responsibility to look at the overall process within the organization related to compliance and ensure that whatever they have oversight of or whatever area they're representing, they're really the ones who are designated to monitor that piece of compliance. And then making sure that we have open lines of communication. This is an ongoing dialogue and kind of that exchange of ideas, the joint review and responsibility within our organization to ensure that everybody knows what the expectations are, knows where to go if they have a question. Sometimes they just want to talk things through, but that there's an open area that people that they can go to who they can just sound things off on. If they have concerns, be able to bring those forward and not feel like there's repercussions within an organization. And then our auditing and monitoring program. Now, I will tell you in some cases that gets confused, the auditing and monitoring process within compliance and the QAPI process. The QAPI process is part of our auditing and monitoring within an organization, but if you have an effective compliance program, it's not your only auditing and monitoring. QAPI is really geared toward patient care within our organization, the compliance, auditing, and monitoring, and the difference is auditing is external, monitoring is internal, is really looking at your organization as a whole and how you're meeting those regulatory requirements and doing the things that need to be done to show that you are an organization who is committed to doing the right thing. And then response promptly to detected offenses. So if we see that there's something going on, this isn't necessarily punitive. It's really putting a plan in place to make sure that we're doing things right, have a corrective action plan, monitoring that corrective action plan to make sure that we stay in compliance, we don't have that happen again. And those guidelines are really generally well publicized so that everybody knows what they are and what the progress is toward that information. Kim, did you want to talk some more about that? Do you have anything
Thanks,
to add?
Lori. Yeah, at this point, I won't add anything because we will be, except to say that over the next 2 webinars, we will be taking a deep dive, if you will, into each of the 7 elements, which these are the areas of overlap, so that you can hear, examples of compliance or recommendations for implementation and opportunities for organizations to assimilate the 7 elements into their own plans and programs.
Thank you so much. Next slide. So on this next slide, you can see those areas of overlap, and they're really all equal to one another. No one is any more important than the other. They all go to a commitment of making sure that we are having good observation, documentation, and monitoring. Now, some places, the only thing we have to offer is our documentation. So we'll talk more about that and other things and why documentation is really so important. And as Kim said, the 7 elements we'll delve into deeper and talk about not only a program, but establishing a plan and evaluating our accountability regarding billing and or care provided. One thing I want to bring up that I don't know that we'll get into in depth, but is a new and a rising area, which is AI. So when we talk about a lot of these pieces, this is a new area that we really have to look into. And I know many organizations to reduce redundancy and kind of control time involved with documentation are using new things that are involved with AI. Just know that that is an emerging area and that you do have responsibility with all these areas when it comes to your documentation that involves AI. Our documentation has to be patient specific. It has to show what the goals of that patient are. And many times this kind of new process doesn't always reflect that. We also see it sometimes in coding. And so you want to be sure that there's a human element in this processes when you're looking at your COP ready and your survey readiness, your billing, and your OIG compliance programs. We are ultimately responsible for everything we submit to a payer. And so it's important that we know what's being reviewed by a regulator and how they're going to view that and that they're able to see what we provide in that documentation that we do. Anything to add, Deb or Kim, from what I said?
Exactly. You hit the important spots.
All right. I think we can move on to the next section.
Thanks, Lori. And I would add that just oh, sorry, I put myself on, right? Some examples, as Lori was pointing out, when we look at the intersection of compliance and regulatory, one example would be in care planning, right? We've seen, for denials where payment denials where the care plan isn't individualized or updated to demonstrate medical necessity. CTIs is an example for hospice where we as an AO will look for the presence of the CTI, but the specific language in the CTI, the technical language that would potentially result in a denial, a payment denial, that's the lens of the government auditor. That being said, if we're on site and we see that the same CTI is copied and pasted from, for every single patient from one, for long length of stay, we may have a question about that. We don't cite on that, but we certainly may make a note of it, especially if it appears as though there's a pattern overall with care and services provided that result in questions about the health and safety of the patient and potential compliance issues. Also, if, for example, we are on site and review documentation for visits, and yet we verify with patient interviews, et cetera, that the patient denies having any services, that's an example of the type of intersection, if you will. We've also seen with hospice, where on the government side, and Lori, you can add in on this, where there may be denials based on aid services being provided in a nursing facility, and yet we know that providing aid services under the hospice program in a nursing facility is part of the providing aid services, part of the hospice benefit. So finding that balance and demonstrating, appropriate levels of care and appropriateness of care and documentation is key when you're looking at all of the lenses of regulatory and compliance and quality.
Yeah.
As we move, go ahead, Laura.
Tim, I was just going to say to your point that you all, as that CHAP as a survey agency, may pick up on things as far as cut and paste and content of items. We are also seeing regulators who are doing billing reviews requesting the plan of care in pieces they didn't necessarily request in the past, because they're also looking at that to see if you're meeting the requirements for individualized care within your organization, and then denying billing because you're not meeting the conditions of participation. So thank you for making that point.
Absolutely. And like I said, that's why this series, I do believe, is so timely and so important for organizations to hear, because there's so many lenses that everyone has to consider, not including daily operations and all of those challenges, but all of the compliance elements as well. So trying to help you focus on how to establish and develop a compliance program is really the key to our series, and helping you understand those, how you can be best supported and where those resources are. So the OIG compliance program history, as Lori had pointed out, this has been in place, compliance program guidance from the OIG since the late 90s, since 1998, with individual program guidance, including home health and hospice, as far back as that time as well. And we'll talk about that in just a moment. It's important to understand that the compliance program in home health and hospice is a voluntary decision, but it is increasingly recommended as a best practice. And certainly, as I had said, for CHAP, we made the decision to include CHAP compliance standards in our CHAP accreditation, because we do recognize the importance and significance of having a well-functioning compliance program. And again, for example, with CHAP, as our accreditation standards align or closely align with the COPs, our compliance standards closely align with the OIG 7 elements. It's also important to note that although we are discussing home health and hospice, compliance and the OIG has demonstrated this guidance. Compliance programs apply to more than just the federally funded payers and providers. Many organizations also receive state funding, and or funding from other sources, other payers that also may require or be beneficial to have an oversight program. And I know that Lori can also attest to, and Deb, that again, there is more than just hospitals, nursing facilities, home health, and hospice. There are many other types of providers that all, such as physician practices, for example, that also can do have guidance in implementing a compliance program. Not having a compliance program or having an ineffective compliance program, as Lori said, does increase the level of risk that the government will bring an enforcement action against the organization. And remember, there's payment enforcement from the OIG compliance standpoint, indictments and CIA's example. There's also survey enforcement. Remember, there are enforcement remedies that can also be put into place, including civil monetary penalties. With having a corporate compliance program or compliance program is certainly beneficial. And I'm the vice president for accreditation for CHAP, and I have been with CHAP since 2023, overseeing all of the AO and accreditation and certification surveys and regulatory side. But my bulk of my career has been in almost 38 years of home health and hospice as an RN in government audit and compliance, as well as survey and regulatory and quality. And I can say from my experience, and I'm going to say that Deb and Lori can also confirm, when an organization is placed under a corporate integrity agreement or requires an independent review organization, but a CIA typically will require an organization to develop and implement an active compliance program. So having one proactively certainly is a strong recommendation. As I said, in 1998, the OIG implemented this major initiative regarding OIG compliance guidance. Some of us have been in the industry long enough to remember Operation Restore Trust, which was the late 90s or mid to late 90s for home health. And similar in a larger way, similar to the target states that enforcement that's occurring with California, Nevada, New Mexico, and Texas for hospices. Back then, you may remember Miami-Dade, Texas, others targeted areas this did result in a moratorium and targeted enforcement. So that at that time, the OIG did implement the recommendations for compliance program. And as I said, there were compliance program guidance recommendations specifically for, in this case, home health in 1998 and hospice in 1999. They are still available. The 7 elements are still relevant. However, my one recommendation would be that if you are implementing your compliance program, take into account what is in place today, because remembering that the examples in the compliance program guidance do not include, for example, electronic medical records, face-to-face as an example, EVV, or as Lori just pointed out, certainly not AI. So, thinking about what those risks are within your own organization in all aspects, and we'll get into a lot of detail about each component of the 7 elements and the best way to implement those elements in your own organization. There has been there is a modernization initiative that is going on right now with the OIG, where all of the service line specific, program specific guidance is being updated. You will see if you go to the website that hospitals, nursing facilities, and laboratories are on the list now. And for 2025, hospice is on the list as TBD, and home health is not on the list yet, but they will be. So the point is, just make sure that you utilize the program specific guidance. What the OIG has implemented and is available and very helpful is the general program guidance, which was published in November of 2023 and is available on their website. And this is a great resource for you to utilize, especially as we're going through the next couple of sessions, because it does provide some updated guidance and recommendations specific to the 7 elements. As well as some additional resources. There are also compliance resources for healthcare boards. There is an updated guidance for the U.S. Department of Criminal Justice, Justice Criminal Division evaluation of corporate compliance programs to help in the evaluation of your program. And as Lori had pointed out, you do want to frequent the OIG website to review the work plan items, because no longer is it a one-time, once a year publication. You actually look and it'll identify for you what the active work plan items are. And also looking at those other corporate integrity agreements so that you can see what the focus of the of audits may have been and what any recommendations or requirements that the OIG is putting into place. The OIG website actually has some excellent resources to help guide you with your compliance program. Some additional compliance information and resources under that general program guidance include adaptations for small and large entities, new entrants in the healthcare industry. We know that this is a target of the federal government. Financial incentives, as well as financial arrangements and tracking, and additional resources. We're going to move into the compliance program infrastructure to be able to just provide a little bit more detail as we prepare, I should say, for our next 2 webinars. As Lori pointed out, the 7 elements have been outlined by the OIG that should be part of an effective, quality, effective, and successful compliance program. These 7 elements are applicable to any setting that is implementing a compliance program, and you will see that as you move forward. And as I said, we're speaking primarily regarding home health and hospice, but if you have a Medicaid personal care program or a personal care program, serviced by private insurance or other payers or some other state plan, you want to consider having that component, that service line, incorporated into your compliance program. I would say the same for an organization that is also billing Part B. So just looking at these elements and thinking beyond just the specific focus of home health and hospice, although this needs to be your primary if that's your primary focus, if that's your primary certification. As I had said before, CHAP standards, we did develop the CHAP compliance standards with very thoughtful and diligent decision that to ensure that organizations are aware of the 7 elements of a compliance program and have a process in place to be able to meet those guidance and mitigate the potential for fraud and abuse. As you can see, our compliance standards do essentially mirror these 7 elements. We have 8 standards, but they mirror these 7 elements. As we go through each of the 7 elements in the next 2 webinars, the 2 webinars in our series, we will spend a little bit more time on each of these standards. Lori and Deb, do you have anything to add as far as the general compliance program guidance?
I think you did a great job. Probably we've made people's ears tired listening to all of it, but there's a lot more detail out there for sure.
That's right.
And there's a lot more detail to come as we keep going, that's for sure. And over the next 2 webinars.
Yeah, I was just going to say, You're welcome to all of you attending, that we did not go through all of the elements in detail today. It really will be more beneficial for you to hear each section, each element in the next two webinars and provide with more detail and resources. But if you have a program and you want to build on that program, or you don't have a program and want to start, in addition to all of the resources that we have provided so far today as to get started, if you will, you really want to start with establishing a culture of compliance within your organization. Remember that compliance is not an event, just like I'll say my soapbox for a moment. Survey is not an event, right? Survey readiness needs to be ongoing, as does compliance, right? A culture of compliance within your organization, to have regulatory and billing compliance within your, to have an understanding of what compliance is and what it means in each individual's role, their role in compliance. And it needs to be weaved into everyday practice. It is the collective responsibility of all of your teams to uphold compliance standards and what your requirements are. And I have this underlined, and you will hear it many times throughout the course of the next few webinars. You need to ensure staff, management, leadership, and board accountability. Every person within the organization needs to understand their role, and also they need to understand, everyone needs to understand what your expectations are, policies and procedures and processes to ensure compliance, and be able to feel within your own organization's culture the ability to be able to report any potential compliance situation and not fear retaliation. The OIG does offer several practical tips to foster this culture, and I underlined one that is important. Just because your competitor is doing something doesn't mean that you can or should. How many times do we hear organizations say, well, the agency down the street is accepting these patients. Agency down the street is doing it this way, or their marketing and sales processes are just much more aggressive. You need to know within your own organization and be comfortable in your own organization with your compliance, because if the OIG knocks on the door of your neighbor and there is any evidence of any sort of fraud or abuse, they will be paying the price. And if they knock on your door as a follow-up, you want to make sure that, again, you're clear that you are in compliance with these requirements. You want to develop and implement a compliance program and plan using this OIG guidance as well as other data. I know that Deb pointed to audit data that also is available. Develop an audit plan and compliance effectiveness and risk assessment. And I do know that Lori and Deb will be talking more about a compliance program risk and effectiveness assessment as a key part of your organization's oversight of your program. Make sure that you do have those regular pre-bill audits and quality audits and compliance audits. As Lori said, it's not a one-size-fits-all. And make sure that you're reviewing the data that you have within your organization, your EMR, not the Pepper once it's available, but any other resources that you have for reporting data, to make sure that you are monitoring your own risk areas. I would say that even though Pepper is not currently published, it's on hold, I would say. Look at the criteria, because the criteria for Pepper does give you an indication of those target areas that the government has been looking at in terms of long length of stay, for hospice days and ALFs and SNFs, no GIP days and others, and just LUPAs, like as Deb pointed out, because if you look at the audit activity that is occurring at the government level, even though they may not be collecting Pepper data right now, it's those audit areas are some of the key areas that they're looking at.
Yeah, and looking at that OIG website will tell you not only what those hot areas are currently, but what's coming. So I think that's important too.
Yes, excellent point. Thanks,
And
Deb.
also one additional quick thing, Kim, when I look at here, include regular pre-bill audits. Remember that your billers, you may think that your billers are doing pre-bill audits, but they're really looking at the check boxes that are there, right? Is the checkbox for the face-to-face, and this is, let's just talk about home health, for example. Is the checkbox for face-to-face there? Is the checkbox for all the orders signed there? Is the checkbox for all the visits there? That's one version of pre-bill audit. That's not looking at the deep dive documentation that goes into what is appropriate for the services that you're doing and the billing. So there's many different audits that we're going to talk about as we continue on the next two webinars. So it's really important to distinguish what all the different types of audits are that are out there.
Yeah, and that remember that it's a quantifiable as well as a quality data
Yep.
issue.
Yes, thanks, Deb and Lori. Excellent points. Making sure, again, that services are provided at appropriate level of care to meet the patient needs, care, treatment, and services. Again, that's an intersection between survey, if you will, regulatory and quality and health and safety, and payment and compliance. Make sure that you do, once you have your corporate compliance program and plan, update that plan at least annually, depending on the needs of the organization. You may find that it's more frequent. And also making sure that you are implementing your compliance program as you have indicated. Training your staff and managers regarding the compliance program on orientation and at least annually, and share your overall compliance program auditing and audit and monitoring results and key risk areas with your staff. And again, you saw it again, staff management, leadership, and board accountability. And this absolutely should be an ongoing agency-wide effort. As Deb discussed at the beginning, this is the second of 4 webinars that we hope that you have found informative. And the next 2 sessions, both on October 9th and October 23rd, we will delve into some of the program elements to be able to really provide more detail on what the recommendations may be, OIG guidance and operational recommendations, as well as resources. Thank you to Deb, and I will give a thank you to Janan Griffin, who actually shared this with us a long time ago as a quote, but it is so true. Readiness for opportunity makes for success. Opportunity often comes by accident. Readiness never does. And so we want to make sure that you all understand that. That is so true. With that, we're going to turn to now to see if there are any questions within the remaining time that we have. And as we do get ready to respond to any questions, just a reminder, the QR code is now on the screen. It's also in your handouts, but if you take the time to scan the QR code at this time, this is where you will find the evaluation for this session, as well as the ability for you to obtain CEUs for attending this session. So thank you, everybody. And we look forward to continuing the journey with you. Dan or Noor, do we have any questions?
We do. So Kim, if you want to open up the Q&A button on your screen, Tammy, if you scroll all the way down to the bottom, there's one. Tammy, that is the very first question. So an easy way to do it, start at the bottom and scroll all your way up, and let's see how many we can get done. Just a quick reminder to everyone, the webinar does cut off directly at the top of the hour. So just pay attention to your time and we're good to go.
Yeah,
Hey,
it looks
thanks.
like the first question is, has there been any official return of PEPR reports in the near future? Have you heard that, Kim?
No, I have not heard an official return. I will say that I was just at the California Hospice and Palliative Care Association conference last week, and it was reported that the website has changed to under construction. So we are thinking that there may be some movement, related to PEPR. But again, what I would say is, look at what those items were, right? The areas that they were focusing on, because we know that consistently this is where the many of the target areas are for audits.
Yeah, and I also think to remind everybody to look at your previous PEPA reports. I mean, because your data trends from there, really you can see what your trending has been. So make sure that you know what your trending has been as well in those PEPA reports.
Yeah, you're still at high risk if you're outside those guidelines, whether they're doing it currently or not. So you want to make sure that if you were outside of one of those expected guidelines, that you're continuing to track that and monitor it, and you have internal data related to that information.
Yeah, excellent point. Thanks. Thanks, Lori. The next question looks as though it's from Nancy Parham. Lori, I'm thinking this is in your wheelhouse. Understanding that in order to really respond, you would need to have more information. But the question is that the patient is not declining, discharge process started, and patient appealed to Levanta and won. Her benefit period ends soon. We're still providing care as required. Are we required to recertify even though our physician, our MD, does not agree?
No, recertification is based on your physician's prognosis statement and the decline of the patient. So if you are unable to support that the patient meets eligibility requirements, regardless of whether they appealed or not, your physician does not have to certify that the patient is appropriate for service. If you have a palliative care program, you may be able to refer them for that or some other type of program they may qualify for, but it still comes down to your physician's judgment for recertification.
Thanks, Lori. Deb, it looks like this one may be for you. What is considered new for the PPEO? Less than 3 years, or what is the time frame?
Yeah, so the PPEO started in 2023, and there was an amendment to the PPEO in 2024. What it actually states is enrolling providers on or after July 13, 2023 would be subjected to a PPEO, and that would start with the date for which the new provider started to bill their first claim. So once your change of ownership, and I'll go through a little bit of those. So what it states is any new enrolling provider in the Medicare program, any provider undergoing a change of ownership consistent with 42 CFR 489.18, which is basically says it's partnership, unincorporated sole proprietorship, corporation, leasing, any of those things leads to the PPEO. Any provider going through a 100% change of ownership via that change of information form. I know that next question says change of administrator. We haven't seen a change of administrator trigger a PPEO, but a change of ownership will trigger a PPEO. And then interesting enough is any provider reactivating a license that has in the past been dormant or put on hold. If you're reactivating a license, you're subjected to that PPEO once you start to bill as well. And we've seen the PPOs, they can be as little as 30 days, or we've seen them last a year. I mean, so there's really no time frame related to how long you could be on this PPO, and they go rounds just like a Target, Approve, and Educate do. The unfortunate thing about the PPO, the further into the rounds you get closer to a decertification of your license. So I hope that answered that question for you.
Yeah, Deb, and I will say that we're also hearing in some states that if you're under a PPEO, you don't do well, it can trigger other state survey audits where they come in and they are repeatedly, very frequently coming into your organization, that even if you have met compliance, to ensure that you continue to meet compliance.
Yeah,
I would agree with
absolutely.
that. Hey, Lori, the next question from Bobby Smith Thompson. What is a good reference to give our hospice medical directors to help educate on relatedness and medications to prognosis? I know that several years ago, NHPCO did have some resources. I believe that the National Alliance for Healthcare at Home, also who is the merger of the NHPCO and NOC, may still have some of those resources. But does AAHPM or are there other resources that hospices can use that you're aware of?
The hospice medical director training has information for that, and I think you can access it even if you're not going for certification. I just want to be sure that I understand this question appropriately, where it says a good reference to give to our hospice medical director to help educate on relatedness in medications to prognosis. I'm not sure I actually understand what the question is. Are you asking, and maybe you can email one of us and let us know, are you asking what medications are considered related? Or, because there is no specific list for that.
Right.
That's really
Right.
dependent upon your organization and what your guidance is and what's going on with that patient and what they're able to tolerate or take or what's appropriate to their plan of care. It's very individualized. If you're asking, do you have, yeah, I'm just not sure I exactly understand. So if you have
I
an
would agree
additional
with that.
question.
I would agree with that, Bobby. If you want to, email back to the group or certainly to Lori or any of us, you can, so that we can answer. We will be any questions we don't get to in the next couple of minutes. We'll make sure that that we receive and that we follow up on. But I would agree with Lori that that relatedness really depends on the patient's situation. It's not a never cover kind of situation. It really does depend on the patient's diagnosis, and their prognosis and related conditions as well.
Yeah, and it's not just your primary diagnosis, it's anything related. So we have to keep in mind that CMS has said to us that as the patient declines, we will see that everything eventually becomes related. So that's a fluid process also that you have to constantly be reviewing, and as part of your update to your plan of care and your comprehensive assessment.
Yes, and I would just add making sure that that documentation is very clear. If the organization determines that the hospice medical director or physician determines that the medication, care, treatment, or services is not related, that needs to be very clear, because with the focus on payment outside the hospice, the Medicare hospice benefit, there is a very clear you want to make sure that there's clear documentation. And according to CMS, not covering care, treatment, and services is it should be rare for a primary diagnosis and related conditions as well. But again, it's in your documentation. I think we just have time for this last question, and then we can follow up with the others. And Laura, you may know this. Are there any resources to obtain compliance certification?
Yeah. So yes, the HCCA is the primary one that's out there, Healthcare Compliance Association, where you would receive certification, and you can find references and information on their website. Back to the previous question, I also just want to say really quickly that it's the responsibility of the medical director to determine and document what is related and unrelated, and if it's unrelated, why.
Yes. Yep. Thanks, Lori. Dan, because we have the hard cutoff, I would like to, we can end our actual questions at this point in time, but if we're able to receive them, Lori, Deb, and I can certainly follow up.
Absolutely. Get you all there in.
Okay, so with that, this does conclude our presentation. As you can see, we have our contact information here, but you also can reach out to the webinar sessions and the email associated with your registration, and we will be happy to follow up. And we really hope that you have found this and the previous session informative, and look forward to having you join us with the next sessions. Thank you, everybody.
Thank you.
Thank you.
Thanks, Deb. Thanks, Lori.
Thanks, Kim. Thanks, Lori.
Bye-bye.